Welcome, MRCOG candidates, to this explainer. Okay, let's just dive right into it. Today we're breaking down the critical guidelines you absolutely need to have memorized for managing obesity and pregnancy safely and effectively. We're going to pull apart the RCOG Green-top Guideline No. 72 and extract exactly what you need to know, in full detail, for both your exams and your daily clinical practice.
To make sure you totally master this for your SBAs and OSCEs, we're going to follow the patient journey chronologically. So we'll start at pre-pregnancy and booking care, then move through antenatal screening, fetal surveillance, planning for birth, and finally intrapartum and postpartum care.
All right, Section 1, pre-pregnancy and booking care. Let's start with establishing the baseline during that crucial first appointment, because really, everything downstream depends on getting this right.
You've absolutely got to commit these World Health Organization BMI classifications to memory. The whole guideline basically revolves around these specific cutoffs. So, Class 1 starts at a BMI of 30, Class 2 at 35, and Class 3 at 40 or greater. Why do we care so much about these exact numbers? Well, as you'll see, they dictate some pretty rigid, evidence-based clinical interventions throughout the entire pregnancy.
Now, when your patient presents with a booking BMI of 30 or greater, meaning Class 1 obesity or above, you must advise 5 milligrams of daily folic acid, not the standard 400 micrograms, but a massive 5 milligrams. Why the huge jump? It's because increased adiposity actually alters folate metabolism, which independently compounds the already higher baseline risk of neural tube defects in this group. And for your exams, remember the timing. Ideally, it should be started at least 1 month before conception and continued right through the first trimester.
The absolute golden rule at booking: measure them directly. The guideline is incredibly explicit that maternal height and weight must be measured using proper equipment to calculate BMI. Never, ever rely on self-reported numbers. You also need to have a frank, multidisciplinary chat about clinical risks, things like gestational diabetes, preeclampsia, and macrosomia. Oh, and here's a massive clinical pearl for you. Anti-obesity drugs like lorcaserin and topiramate are strictly contraindicated in pregnancy due to severe risks like oral clefts and lower birth weights.
Okay, moving on to Section 2, antenatal screening and risks. Let's see how this builds into our specific screening protocols in the second trimester. Notice the physical reality we're dealing with here. A higher maternal BMI literally limits ultrasound clarity. The increased echogenicity of adipose tissue just means lower sensitivity and a much higher false negative rate for anomaly detection. Since we know this, you've got to allocate more time for these scans. You also need to warn your patient about the high likelihood of repeat visits. And honestly, be ready to use a transvaginal approach, especially for nuchal translucency measurements. So, if your patient hits a BMI of 35 or more, that's Class 2 obesity. Plus, just one other moderate risk factor, like maybe it's their first pregnancy or they're over 40, you must initiate 150 milligrams of daily aspirin starting from 12 weeks. This is an absolutely critical evidence-based intervention to prevent preeclampsia, which this specific demographic is at a significantly higher risk of developing.
Right, here is a classic SBA-style scenario for you. How exactly do we manage the severe venous thromboembolism risk inherent to a BMI over 30? We already know obesity is an independent risk factor, but what does the guideline actually tell us about dosing the prophylaxis?
The guideline is super clear here. You need rigorous, individualized risk assessments at booking and, frankly, anytime the patient is admitted. But the big takeaway? Weight-based, low molecular weight heparin dosing is vastly superior to fixed dosing for your Class 3 patients. Standard fixed doses just completely fail to achieve prophylactic anti-EXA levels when you're dealing with higher adipose volumes.
Let's shift gears to Section 3, fetal surveillance protocols. As we get into the third trimester, our standard checks need some very specific adjustments.
Think about your standard ward rounds or those really busy clinic days. At what specific BMI threshold does your trusty tape measure completely lose its clinical value for predicting a small for gestational age fetus?
It's 35. The second that BMI crosses 35, the guideline is absolute. Symphysis fundal height measurements become way too inaccurate. You must automatically refer these patients for serial ultrasound assessments of fetal size instead.
All right, Section 4, planning labor and birth. As we near the end of the third trimester, we really have to look at the logistical and clinical planning for the birth itself, which takes a ton of multidisciplinary coordination.
This is a massive threshold that examiners just love to test. When is an antenatal referral to your obstetrician anesthetist not just a good idea, but explicitly, absolutely required by the guideline? It's 40. A BMI of 40 or more triggers what I like to call the mandatory third trimester trifecta. First, you need an anesthetic referral to formally assess for difficult airways and regional block challenges. Second, a formal moving and handling risk assessment. And third, you need a documented tissue viability assessment using a validated scale to prevent pressure sores.
Now, for your clinical governance OSCE stations, keep this in mind. All maternity units have to maintain a documented, central list of safe working loads and dimensions for all bariatric equipment. You need to know exactly where the large blood pressure cuffs, the bariatric operating tables, and the heavy-duty hoists are located long before the patient ever walks through the door in labor. Finally, Section 5, Intrapartum and Postpartum Management. Let's dive into the sharp end of care, executing these plans on the delivery suite. When a high-risk patient with Class 3 obesity goes into established labor, you've got to act fast. Follow this exact escalation pathway with zero delay. First, inform the on-duty anesthetist immediately and make sure it's documented. Second, get venous access early. Honestly, strongly consider citing a second cannula right away because getting vascular access is only going to get exponentially harder if an emergency develops. And third, ensure the patient receives continuous one-to-one midwifery care so you can monitor for any sudden changes. And as we actually get to delivery, do not forget that obesity independently skyrockets the risk of postpartum hemorrhage, even when you correct for the mode of birth. Because of this, active management of the third stage of labor is absolutely vital. It's highly recommended by the guideline to aggressively cut down that PPH risk.
If you end up doing a surgical delivery, there are 3 absolute pearls you need to remember to protect your patient from severe post-op complications. 1. Prophylactic antibiotics are mandatory at the time of surgery for all C-sections in women with a BMI of 30 or greater to fight off that uniquely high risk of wound infection. 2. If the subcutaneous fat is more than 2 centimeters thick, you absolutely must suture that dead space to prevent wound separation. And 3. If your patient weighs more than 90 kilograms and is on therapeutic LMWH, you've got to routinely monitor their anti-EXA levels.
So we've walked through the entire clinical pathway from Green-top Guideline 72. Memorizing these precise cutoffs, the 30s, the 35s, the 40s, isn't just a trick to pass the MRCOG. It's really about delivering incredibly safe, proactive care in a setting where risks compound unbelievably fast. But I want to leave you with a real-world question to think about. Are your local unit's bariatric pathways actually robust enough to handle a sudden emergency, or are we all just ticking boxes? Thanks so much for joining this explainer, and best of luck with your exams.